Good morning, everybody. Hello. I heard like one lone hello from the front. Good morning, everybody. Ah, I love it. Thank you so much. I'm Matt Salo, and I'm the executive director here at the National Association of Medicaid Directors. And I want to welcome all of you to our sixth annual meeting here in Washington, D.C., or as we like to call it, 2 days in which we hope you're not going to have to think anything at all about the election. As I said, we have been doing this now for 6 years, but this is our first year in a brand new hotel. Nicer, bigger, more roomy, fantastic bacon and other good breakfasts, so I hope you are enjoying that. I'm really excited about, now we've had our state people here for about a day and a half or so, but I'm really, really excited about the next day and a half with the content that you're going to see in the plenary sessions, one of which is going to start very, very soon, as well as the breakout sessions throughout the next day and a half, where we really try to give all of you a taste and a flavor of what's on the mind. Talking with Vicki Wacchino from CMCS, with a retrospective of what the last 8 years have meant for Medicaid and the people that we serve. So I want to take a moment, do a couple of housekeeping things. I really need to make sure that we acknowledge all of the people who have made not only this meeting, but this association and everything that we do possible. So I'm going to start off with appreciation for the folks, super hardworking folks on my staff. Many of you may know them, but I'm going to ask them to at least step up, step forward, stand up, and wave, so you know who they are, and let them know that you appreciate what they do for all of you. So I see already standing up on the side there, Lindsay Browning. I'm doing a bad job of visually tracking my staff, so Jack Rollins right here, stand up. The newest member of our staff, Cornelia Luberes. Where's Cornelia? There we are, thank you. And then if you don't see her, she's running around making things work, Tess Moore. Oh, Tess, thank you. And then I want to do a last and not least and somewhat bittersweet, but if you've been following NAMD's activities for the past, for our history, and appreciated much of the voluminous work that we've done around, basically everything, legislative issues, regulatory issues, everything. A huge component of that has been Andrea Maresca, our Director of Federal Policy. Andrea is in the back. And I say somewhat bittersweet in that this is going to be her last week with NAMD. So this is going to be a big hole to fill, big shoes to fill. But the good news for all of you is that I'm hiring. So let's talk about this afterwards. And if you've got what it takes, we're hiring. I also want to thank all the good folks with our conference planners, ARB Meetings and Events. They've helped us take this meeting from relatively small to really big, really fancy, and super smooth running. They've done such a fantastic job. So Ann Michaels, in the back right there. And then I think the rest of the folks who are probably not here but are making things run smoothly at the reg desk and behind the scenes, Tara Adams, Becca Dorsky, Jillian Lacricchio, and Victoria Van Steenberg, who is not here at all because she is 9 months pregnant and back home in Louisiana. So thank you to all of you guys. This whole conference is a breeze to deal with because you do such a wonderful job for us, so thank you. So I also want to take a moment to thank the sponsors, without whom much of this conference would not be possible or affordable. We've got a lot of sponsors. We've got a lot of people. We've got a huge exhibit hall. We've got a lot of great sponsors. I'm not going to take the time to thank literally all of them right now, but I do want to prioritize those who have stepped to the forefront of the the sponsorship options and made the most of the engagement with us. So first of all, our platinum sponsors, Aetna. Thank you guys. You've got at least 3 former Medicaid directors on staff, which we always appreciate from our Alumni Association. At the diamond level, and who also sponsored our hotel keys, AmeriHealth Caritas, and you get terrific work, you guys. Thanks for being partners. At the diamond level, and also who sponsored the breakfast, which I hope you enjoyed. I certainly did. I love the bacon. I love the hash. Bacon's the theme for me today. I don't know, but Centene. So thank you, Centene. And then our other diamond sponsors, which include Blue Cross Blue Shield of Illinois, Montana, New Mexico, Oklahoma, and Texas, the Lewin Group, Optum, Sellers Dorsey, and WellCare Health Plans. And then finally, well, not finally, but in addition, CGI is sponsoring today's networking lunch this afternoon. And then finally, Alkermes is sponsoring a couple of different things, one of which is the complimentary Wi-Fi that you will see in this room and throughout the meeting rooms. If you want to sign up to it, just go to your Wi-Fi settings, look it up, it's Alkermes, and then the passcode is Alkermes16, and that'll keep you Wi-Fi connected. But the other thing that they helped us put together is the mobile app for the conference that you can download on your phone, no matter what phone you have. And if you haven't done so already, I encourage you to do so. All the information is there at a glance. It's very convenient. I've got it downloaded. It's great. You can just search for it under NAMD 2016 in the app stores. It'll come right up. Then in an attempt to appeal to the youth demographic, which I think is always important at meetings like this, we're doing a little twist on the Pokemon Go craze, and we've got a feature on the app called NAMD Go. And it's basically, it's a thinly veiled effort on our behalf to get you to mingle through the exhibit hall and engage with the exhibitors and the sponsors, but there's lots of little things over the course of the next day and a half that will get you points. And the number 1, number 2, and number 3 leaders at the end of the conference will get some really fantastic prizes, including some Bose Quiet Comfort headphones, an Apple Watch, and an Amazon Echo. So we will actually be announcing that at the beginning of the closing lunch tomorrow at 12:30. So by all means, load that up and start your hunt. I don't think there will be any actual Pokemons, but it should be good. And then so finally, I want to thank NAMD's board of directors for their tireless work to help inform and guide and shape the work that we do on behalf of the Medicaid directors. They dedicate a lot of their time that they could be spending trying to, lead their own states, but they dedicate time to helping lead all of the states. So I want to at least acknowledge them today. I'm not going to ask them to stand up because, then it just kind of puts the targets on them, but you know who they are. You'll find them. So, first and foremost, I want to thank Tom Betlach, the Medicaid director in Arizona, who is our board president. He unfortunately could not be here today due to a family illness, but our thoughts and our prayers are with him and his family. But then also John McCarthy, Medicaid director in Ohio, who is our vice president. You will actually hear more from John later in a few minutes at the next panel. Our regional board representatives in the West, Marianne Lindeblad of Washington and Judy Moore-Peterson of Hawaii. In the Midwest, Joe Moser of Indiana and Susan Mosier of Kansas, although she has been promoted up as secretary, and so we have said our goodbyes to her on the board, but she's been terrific for the past couple of years. In the South, Christian Sura of South Carolina, and then Justin Senior of Florida. Justin Senior also has been promoted up, and so will be leaving the board, but we have appreciated his efforts. And then in the East region, Kate McAvoy in Connecticut and Shannon McMahon in Maryland. You will also see a little bit more from Shannon in our next session. And then Sandra King Young from American Samoa who is doing the yeoman's work of trying to help put the issues of the U.S. territories more at the front of a legislative and regulatory agenda for all of us. And I think it's important to keep those issues in mind. So the last thing I want to do is just touch real briefly, take about 10 minutes, I think, to go over a couple of points of information, sort of context setting for the next day and a half. I think many of you know that we are really proud of the work that we do in partnership with the Kaiser Family Foundation around the annual Kaiser NAMD Medicaid Budget Survey that HMA works so hard on. But one of the things that we also do is an annual operations survey, where we take a really unique look at the structure and the agenda, the priorities, and the challenges of state Medicaid directors and state Medicaid agencies. And we are in the midst of finalizing our report this year. It's not quite done, but we do have a couple of slides that I wanted to show just to kind of give folks a flavor for what the Medicaid agency priorities and challenges look like, because like I said, I think that helps put some context for the sessions that we're going to be looking at over the next couple of days. So if I can get those running on the slide. There we go. All right, thank you. So basically what it is, we try to look at, I realize those are small, but I'm just going to tell you what these are. The things we look at are agency structure, budget, enrollment, priorities, roles and responsibilities, program integrity, delivery system reform and other types of program innovation, staffing and capacity, marketplace coordination, director backgrounds, and then roles and expectations. We should have this done and ready to release within the next couple of weeks, but again, I wanted to share just a couple of quick things as takeaways. Looking at the size of the Medicaid program, it really does vary pretty significantly from state to state. The smallest Medicaid program around $650 million a year, the largest at $87 billion. Medicaid is a Fortune 50 program or Fortune 50 company in pretty much every state, and is very significant. And you can see some of the breakdown of the state and federal spending. But it's also really important to note just how complex Medicaid is. And as you all know, that the face and the vision of Medicaid is often pregnant women and kids and low-income families. And as you can see, that's who makes up the bulk of the population. 46% of the population in Medicaid are kids. But as you know, that's not really who drives the budget. And what really drives program spending are seniors and people with a broad spectrum of disabilities. And just some of the characteristics of the Medicaid population are pretty significant in that 20% of Medicaid beneficiaries have a behavioral health diagnosis. Medicaid beneficiaries, 7% of them have lost all of their natural teeth. 17% have asthma, 10% have diabetes, 20% are unable to work due to a medical condition. These are some of the challenges that trying to better serve the Medicaid population brings, and this is what makes the opportunities and the efforts that we've got underway in so many states really exciting, because these are the problems that need to be fixed in the healthcare system. And so, looking at what, some of the other characteristics, a lot of states are doing non-traditionally Medicaid things, and we've got 28 agencies reported that the Medicaid agency or the Medicaid director is managing separate programs to do supportive housing, to do old age pensions, services for immigrant kids, non-emergency transportation, telehealth, and foster care services. This is not your grandmother's Medicaid program. This is an evolving program in terms of the complexity that Medicaid directors and programs have to deal with. Another thing we looked at was trying to get a glimpse at how program services are being delivered. And we know that there's lots and lots of talk around managed care expansions and managed care improvements. And we took a look and we saw that 37 states reported that the majority, more than 60% of the beneficiaries, are in some kind of managed care. and only 7 states indicated that the majority of their beneficiaries are in fee-for-service. So you can see a little bit of the dichotomy there. Interestingly enough, only 1 state said that there's about a 50-50 mix between the two. So you can pretty clearly see this is where a lot of states, not all states by all means, but where a lot of states are going in terms of their changes. One of the things that I think it's a really important takeaway is we ask our folks, what are your priorities? And what we see from this chart, and I recognize the wording is small, I'm going to tell you what it means though. The priorities that we see from our membership, number 1, far and above, are delivery system and payment reforms. So that can be managed care types of things, that can be dual eligible integration, behavioral health integration, looking at social determinants of health, and payment reforms, shared savings, and other types of value-based purchasing arrangements. That's the number 1 priority as expressed by our members. Second most oftenly mentioned priority is systems and IT issues. And that's kind of a relatively new top 3 issue for us. And I think it's really kind of calling into focus the need to make sure that our eligibility systems, our information systems, our claims processing systems, our data analytics are really up to the task. And you really need to know the problems you're facing if you're going to fix them. And so this has been a huge focus for a lot of folks. And then the third big priority or the third largest priority that we've heard states articulate are behavioral health and substance use disorder issues. Now again, that's going to run a fairly wide spectrum from looking at mental health parity, to looking at the IMD exclusion, to looking at substance use disorder waivers, to looking at the opioid crisis, or maybe even just trying to better integrate behavioral health care services into the acute care model in Medicaid. Lots of other priorities, but those are the top 3, and I think those are important takeaways. And I think you'll see these themes reflected in a lot of the sessions that we've got over the next day and a half. I also want to talk about the challenges. So it's not all wine and roses for Medicaid directors. There's a lot of challenges they face in trying to fix these problems and to run a program of that size in an increasingly challenging environment. The number 1 challenge reported by our folks, staffing. Very high vacancy rates, difficulty getting people at the right skill levels on board, the challenges of state pay scales, trying to compete with the private sector, trying to compete with the federal government, trying to compete where have you. And the second biggest one was data and the IT infrastructure. And I think, I don't want to steal his thunder, but the Medicaid director in Nebraska, Calder Lynch, likes to point out that he is in fact younger than his systems in Nebraska, and that's kind of an interesting perspective when you think about it. There may be others out there, but that's upgrades are needed, and we're moving towards modularity, and maybe we'll know that when we see it, but it's a huge issue. And then finally, just the administrative budget. I think the challenge is that so much of what is needed is going to take investments, and investing in the administrative capacity of Medicaid is, quite frankly, never a politically popular option in most state capitals and with most state legislatures. So these are real challenges. There are more. And yeah, I'm going to kind of go through that one. But then to kind of hit back on a little bit of a glance at the experience of the Medicaid directors. And as you can see, the majority, more than 60% of Medicaid directors are new to their positions, 20% being there less than a year, 40% less than 2 years, with a small outlier of 8+. So there's a lot of turnover, and I think the other key thing is that we look at the median tenure, and actually the median tenure of the Medicaid director is up this year. It's 19 months. It was 17 months last year. But it's a pretty significant decrease from a couple of years ago. You know, when we looked at this in 2013, the median tenure is actually about 3 years. And I think one of the things we saw is that at that point, Medicaid directors were, you know, elbow deep in trying to figure out how to make all of the mandatory ACA changes happen. And that a lot of the normal, you know, cycle of, you know, people moving on, people finding better jobs or better paying jobs, or getting burned out and trying something different, just slowed to a halt because Medicaid directors couldn't leave in the midst of that massive, massive change that was going on. And then once we kind of got through that and a lot of the systems changes were put in place, we saw a pretty significant, you know, sort of the floodgates were opened and people started to leave. And so now we're back down again to a median tenure of about 19 months. So I just wanted to leave you with that, you know, because as we look at Medicaid, you know, there's never been a better opportunity to do some really exciting, really productive, really innovative things for the most vulnerable, fragile, and medically fragile people in this country. Those things are going to be difficult. The delivery system reforms, the payment reforms that are underway are going to be difficult. And the Medicaid directors are all very, very hard at work trying to figure out how to turn the battleship around in the bathtub, trying to fix the underlying healthcare system. And they're doing it understaffed, overworked, under budget, and oftentimes underappreciated. I appreciate you. I hope all of you appreciate them. Be nice to your Medicaid directors because together we can do this. And I will just leave with what we're doing to try to help them is we try to foster the state-driven innovation, whether it's amongst our members or with our federal partners. We try to ease some of the operational challenges, again, by engaging with the administration and other folks. And really, we try to help build relationships between the Medicaid agencies and all of our partners. And I really see that Medicaid, the future of Medicaid is in many ways a public-private partnership. And we try to be very good stewards of the public trust and the public taxpayer dollar, and we want to be good partners to you and want you, the private sector, to be good partners to us, because together we really can make all of this work. So I will end on that very positive note and say thank you all. And then I'm going to call up Shannon McMahon, who is the Medicaid director in Maryland and a member of the NAMD board, and a self-proclaimed Dreamland groupie, to introduce what I think you were all waiting for me to just hurry up and stop talking, to introduce the next panel on the opioid crisis in America, and a look at the book Dreamland and what the states and the federal government has done and can do to try to address this problem. So with that, thank you all for being here, and I welcome our esteemed speakers up to the podium.
Good morning. With that rousing introduction, I'm not really sure if I can recover, but and especially since I get to sit up here with Sam Quinones. I will admit that I did read Dreamland on the only vacation I took this year, and I guess that does make me a groupie. So good morning again. I'm Shannon McMahon. I'm the Deputy Secretary for Healthcare Financing at the Maryland Department of Health and Mental Hygiene. It really is my privilege to be here today. And in Maryland speak, that means I'm the State Medicaid Director. So Maryland, like so many other states, is really knee-deep in the opioid crisis. We have seen significant increases in heroin and opioid-related abuse and deaths. Between 2014 and 2015, heroin-related fatal overdoses rose 29%. And deaths from fentanyl rose 83%, while deaths from the misuse of prescription drugs increased an additional 6%. The October 2016 Kaiser Family Foundation survey that was jointly done with the National Association of Medicaid Directors did a terrific job of highlighting all of the things that are happening in Maryland. Some of them are not so great, but I would like to talk a little bit about some of the things that we're actively working on to really combat the opioid epidemic in Maryland, because Maryland is a very unique state in both our geography as well as our political structure. So we're very active in Medicaid, in particular in interagency efforts to promote prevention, treatment, and recovery to reduce opioid deaths. We're actively working with our managed care organizations, and we'll be implementing a consistent set of prior authorization and step therapy strategies that go above and beyond the CDC guidelines that were issued earlier this year. We are also in the throes of implementing expanded prior authorization for fentanyl and methadone for people in our fee-for-service program, as well as in our managed care arrangements. We've created new value-based purchasing arrangements for the purchase of methadone and other anti-opioids, including Vivitrol, that incentivizes both therapy and the pharmaceuticals. In addition, we continue to expand and enhance the use of our prescription drug monitoring program, as many states do, and we've integrated that into our very well-esteemed health information exchange. The state is also implementing enhanced education efforts for fee-for-service and managed care, and we're sending letters to patients and providers when patients are receiving high-dose or other high-risk combinations of drugs. On the treatment side, I was really excited that I was going to say we're very close to being the second state that would have a waiver to provide Medicaid-financed inpatient substance use services in IMDs. I understand that Massachusetts got approved last Friday, so we're going to be number 3. And access has been a challenge of us because of this lack of federal funds for treatment in IMD. So we're very eager to continue partnering with the federal government to move forward with a broad continuum of Medicaid substance use services. Furthermore, it's going to align with our longstanding strategy of financing medication-assisted treatment, both for people who are insured and uninsured. So it is through this lens that it really is my privilege to introduce our keynote speaker along with our reactors. First, Sam Quinones, the author of the 2015 journalistic history book, Dreamland. The book tells in painstaking detail the story of the unfettered prescribing of pain medications during the 1990s, and when it reached its peak in Purdue Pharma's campaign to market OxyContin, its new, expensive, and extremely addictive miracle painkiller. While at the same time, the book details the influx of heroin into the US and its impact on small-town America in nearly all of our states. On a personal level, I'm pleased to say that there are several beat-up copies of Dreamland floating around Maryland Medicaid. There's also a stack over there that are probably going to be some Christmas gifts that I'm hopeful Sam will sign for me. And it really isn't, there are very few days where we don't talk about how this book has influenced some of our thinking and our strategies as we move forward to try to combat the opioid epidemic. In addition, I'd like to start to introduce our reactors. Mike Botticelli, who was sworn in as the Director of the National Drug Control Policy at the White House on February 11th, 2015. He was unanimously confirmed by the Senate and joined the White House ONDCP as the Deputy Director in 2012. He later served as Acting Director. As the Director of National Drug Control Policy, Mr. Botticelli leads the Obama administration's drug policy efforts, which are based on a balanced public health approach and public safety. Mr. Botticelli has more than 2 decades of experience supporting Americans affected by substance use disorder and has been in long-term recovery himself for more than 26 years. He has encouraged millions of Americans in recovery today to make their voices heard and confront the stigma associated with substance use. Finally, our final reactor is Mr. John McCarthy. Mr. McCarthy is the Director of Ohio Medicaid, and as Matt said, he's also the Vice Chair of the National Association of Medicaid Directors. He's one of the longest-serving Medicaid directors. He's been in his role since 2011. And since he's been in the position, the role of the Medicaid director in Ohio was elevated to cabinet level. Mr. McCarthy and his team have implemented a series of innovative policy initiatives that have modernized the Medicaid program by improving the quality of health services at a substantial value to the Ohio taxpayers. Prior to overseeing Ohio Medicaid, Mr. McCarthy served as the Medicaid director for the District of Columbia and spent 10 years in consulting with state Medicaid programs. Of particular interest to this discussion is, of course, Ohio's front and center place in the history of the opioid epidemic and in the Dreamland book, which describes so much about the opioid epidemic and how it transformed the once vital blue-collar city of Portsmouth, Ohio, and other American communities in the heartland into the throes of addiction. In terms of format, I'm going to invite Mr. Quinones to make his remarks, followed by Mr. Botticelli, and then Mr. McCarthy will serve as the reactor. and I'll facilitate some discussion after the presentations. So please join me in welcoming Sam Quinones, the author of Dreamland, Mike Botticelli, and John McCarthy.
Sit down or what? Oh, that's fine right there. There we go. Let me grab a bottle of water. Okay then, how you guys doing? Good? All right. It is so great to be in the nation's capital. I love coming here, no matter what happens in our electoral politics. I lived in Mexico, you should know, for 10 years. And I love Mexico, but when you come to this city, it reminds you how enormously great it is to be American and the enormously beautiful values in this country. Regardless of the electoral stuff, we had the privilege, my wife and daughter and I, coming here over the summer, having lunch with Mike Botticelli. Very great moment in our lives, honestly. My daughter still talks about this. And we went to see the Supreme Court, the Congress, the Smithsonian, this amazing jewel, a national jewel, and it's just so great. I hope you all, while you're here, have a chance to see a little bit of Washington. I came away in the middle of all this election enormously inspired whenever I visit here, and that trip was no exception. I really thought when I was invited to do this that there would be like about 100 of you guys, because I figured how many people? There's only 50 states, right? And so there's going to be one, and then maybe a staff, and so maybe let's say 150 people, right? And it's like I can't even see the end of y'all out there. So. Anyway, I'm going to put this here. We do have a very serious problem on our hands, and it is nationwide. I was speaking with someone earlier from New Orleans. I've been in Salt Lake. I've been in, I've got trips planned to Vermont and New Hampshire, obviously Ohio, Kentucky. This is a problem. When I was writing my book, I have to say, one of the things that struck me was, or one of the things I thought would happen is the book would come out and it would just simply die. Because when I was writing the book, there was nobody out there who really wanted to talk about it. Primarily, I would say parents. Parents just did not want anyone to know how their children really died. So all across the country, as one guy told me, all across the country, hundreds of thousands, maybe millions of parents, all alone in their rooms, cradling a photo album, crying themselves to sleep at night, and the greatest fear they have is that someone will figure out that their boy did not die of a heart attack at 25, but instead died on a McDonald's bathroom toilet with a needle in his arm. So it's an amazing moment we have, unlike any other, I think, frankly, in terms of drug problems that we've faced. So today I'd just like to talk a little bit about my conception of what happened. And I think it begins, really, in 1980, where a doctor by the name of Herschel Jick in Boston University, who ran a big database of hospital patients, decided one day to ask the database, this was 1979, really, what happens when, how many patients in that database were given narcotic painkillers while in the hospital, and how many of those got addicted. He was used to asking the database questions about how drugs were used and prescribed, not just opiates, but all kinds. And by then he had 300,000 people in the database. And the numbers he cranked out were 11,000 plus people were given narcotic painkillers, and 4 of those, while in hospital, and 4 of those got addicted. So he wrote this up in a 101-word letter to the editor, sent it into the New England Journal of Medicine. In due course, the journal published it in January of 1980 under the heading, Addiction Rare in Patients Treated with Narcotics. At the same time, across the country, completely separate. In San Fernando Valley of Los Angeles, migrants from a small town in Mexico, in the small state of Nayarit, a small town called Jalisco, had migrated to the San Fernando Valley, and a few of them knew how to cook opium goo into black tar heroin. Opium, poppy, you should know, grows very nicely in the mountains of Pacific Northwest Mexico. They had learned to cook this into a substance called black tar heroin, which, if you're like me, I grew up in the 70s, you'd never seen anything but white powder heroin in those movies, The French Connection and all that kind of stuff. Black tar heroin is actually more common, and it looks like Tootsie Roll. It's every bit heroin. It's just not as processed as the white powder. And they learned to cook this, and a few of those families, only a few, began selling this in parks, chipping off little pieces to the addicts who would come up to them in the San Fernando Valley in the parks there. In time, though, more and more people from this town figured out that this was probably a good business to get into, and they saturated the market. In time, cops figured this out, began to make arrests, profits dwindled, and so they moved to the thing that kind of revolutionized the system. They moved to cars, and they began to drive around, expanding their market beyond simply the park to a lot, and in time, they began to take orders. So it became a system very much like pizza delivery. Back then, it was with payphones and pagers. Later on, of course, cell phones revolutionized the system even further. But it became a system very much like pizza delivery. An addict would call a number, the operator would call the driver, and the driver would go deliver the heroin to this person. There were several things that distinguished this system from every other kind of drug trafficking that we've seen in America. And that was, first of all, that these guys were paid a salary, a lot of the drivers. They had business hours, 7 in the morning, 7 at night. They did not use guns. They did not kill each other. Most underworld systems have been, the way you get market share is you kill your rival. Al Capone started that. The Colombians, Bloods and Crips, you've seen this many, many times. These guys were different. No guns. They were all competing with each other, but they were all friends with each other because they were all the same town. Sometimes they were cousins. They went to kindergarten together. In time, this system, though, the profits began to drop. And as the profits began to drop, they did what any capitalist franchise or capitalist enterprise does. They expanded. Meanwhile, pain specialists across America were discovered this letter that Herschel Jick had written back in 1980 and published in the New England Journal of Medicine. These pain specialists were young Turks. They were trying to kind of change pain management. Pain management was very new. They came from a period where they saw people not treated for their pain. People dying of cancer in horrible pain, and doctors still would not provide opiate painkillers which would relieve their pain. They began to think this was wrong, and kind of a cadre, kind of a group, a revolutionary fervor, I think, formed among a lot of these doctors. They began to look around and they began to argue that we needed to make much more aggressive use of opiate painkillers. That these were tools that we had a duty, a mission to use more aggressively. And in time, they won the battle for terminal cancer patients. And they began to say, people began to say, what do we care? People are dying of cancer. If they get addicted the last 3 months of their life, at least they'll have a life free of pain those last 3 months. But they kept pushing. And they kept pushing, and they kept pushing, or we would not be here today. They discovered the letter to the editor. What had happened was they were really looking for evidence that these pills could be used far more aggressively, not just for terminal cancer patients, but for all kinds of pain. They came up with the idea these pills were now known to be virtually non-addictive when used to treat pain. That less than 1% of all pain patients who were treated with these pills got addicted. There was no evidence for this. But they were kind of revolutionary in their fervor. Ends justified the means, and they began to look for evidence, and the one place they found none except for one letter buried in the back of a 1980 New England Journal of Medicine edition under the heading Addiction Rare in Patients Treated with Narcotics. They rescued this letter from the oblivion that Dr. Herschel Jick intended for it. and made it a cornerstone. It became the intellectual cornerstone of the opiate movement, the pain revolution that began to take place in the late 80s and really got revving in the 1990s. As all this was happening, meanwhile, the Jalisco boys, the guys from the small town in Jalisco in the state of Nayarit, were expanding their system. They did so without guns, as I said. They did so instead through marketing. This was a time of no growth in the addict population. So if you landed, a couple of your crews landed in Salt Lake City competing with each other, they couldn't kill each other. They knew each other. They knew where each other's mothers lived back home. So they had to use something else. They became master marketers, branders. They would offer discounts. You buy from me 6 days a week. I give you a free one on Sunday. Bring me 5 new addicts. I give you 50 free balloons. They hung out in front of methadone clinics, giving away free dope to methadone patients at the clinics. Sometimes they even developed personal contacts with the addicts. The idea was, stick with us. You get out of jail, here's 5 free balloons to welcome you back to drug use. And it began to expand. They began to expand throughout the western United States first. Again, Salt Lake, Reno, Portland, Seattle, Albuquerque, Denver, on and on. They did so based on a classic thing. They did so based on cheap Mexican labor. I always wondered, as I was getting into this story, how it would be that guys back home in this village would see their friends arrested, because cops could arrest these guys fairly easily. How it would be that guys back home would see this and still raise their hand to come north and drive heroin around the town in Reno or in Portland someplace. One of the ways, as I got deeper into this story, one of the things I realized was what was going on back home. I visited this town, and I saw one of the things that was really important in driving labor was that this system of delivering heroin like pizza, was a magnificent system for transforming very, very cheap black tar heroin that they could make for about $1 a hit into stacks and stacks of Levi's 501 jeans. Back in the 1990s, when this system was especially expanding, Levi's 501 jeans were the gold standard of rural Mexican menswear. If you had that, if you had a pair of Levi's, you were kind of assumed to have arrived in a kind of a socio-economic sense. The guys doing this system realized, there's all these addicts. They are magnificent shoplifters. And they began to make orders with you bring me a pair of Levi's 501s, I'll give you a free hit. Soon they were making lists of the sizes. My uncle needs this size, my friend needs this size. They would develop huge stacks of these things, take them home, and give the pants away like Santa Claus. Kids back home in their cheap Mexican jeans saw their friends walking around the plaza. Brand new jeans on, all the girls wanted to talk to them. And pretty soon, boys, for an entire generation of boys, were raising their hands to say, I'll do that. I'll go north and drive heroin for a while if it means I can rise socially. So the system spread. The system spread through the 1990s, spread throughout the western United States, and cops could not arrest enough of them. Important to keep in mind that this was not a cartel. This was not a drug cartel the way we think of them in Mexico. It's a business model, a system that just kind of worked for everybody. The kids who were involved in it were not killers. They were avocado growers. They were sugarcane farmers, bakers, butchers, all jobs leading nowhere. All jobs meaning that you could not accumulate land, a truck, anything that would make you marriageable. These kids were very polite. The guys that I interviewed always used the form of you, usted, which is a formal way of saying you in Spanish. They just really wanted their $5,000, their $10,000, and go back home and buy a house and change their lives. That was the idea. However, they were also, it's very important to understand, they were part of a much larger story that was going on at this time. Back in the 70s, up until the 70s, until the 80s really, a very large chunk of our heroin came from the Far East, from Burma, Turkey. French Connection dope came from Turkey, Thailand, places like that, Afghanistan. 1980s, that changed. Mexican and Colombian heroin outcompeted the heroin from the Far East. And it did this because heroin's a commodity. And so how far you have to travel is reflected in the price. Heroin from the Far East would get cut every time it changed hands, and by the time it would reach the street, it would be 6 to 10% pure. The heroin from Mexico didn't have that far to come, didn't change hands that much. It arrived much more potent and much cheaper, and nobody noticed. Nobody noticed in the 1980s, early 1990s, because we had other drugs that were far more important, causing far bigger problem, crack, then meth. Nobody cared when this system, except for the DEA, who noted it with every annual report. By the mid-1990s, as all that was going on, the pain revolution was really gaining serious traction across America. This was a time, remember, of kind of a sales force arms race among pharmaceutical companies. So every pharmaceutical company was hiring more and more people. Purdue, I'll get to later, had 1,000 pharmaceutical reps out there, sometimes almost tripping over each other in some areas where they were heavily promoting this. In 1993, we had about 30,000 sales reps nationwide. By 2003, had about 120,000 sales reps. But it was also another period in which Americans themselves were getting far less impatient with pain. We came to believe that we were kind of entitled to a life free of pain. The doctors were there to magically fix us. They were like car mechanics, and we were cars. Our bodies were cars, and therefore we expected them to just do their magic. And by the way, we were not going to participate and be accountable for our own health choices, wellness choices. At the urging of pharmaceutical companies, I'm sure a lot of you know a lot of this, but I'll just very quickly go over it. At the urging of pharmaceutical companies and others in medicine, pain was deemed the fifth vital sign. The idea was that we now had to spend far more of our resources addressing pain, and one way to do that was to tell doctors that we now believe pain was a vital sign. And we were in an epidemic of pain. A country, all across the country, were people who were not being treated. We were treating pain poorly, was the idea. In time, doctors became pressured to prescribe opiate painkillers. We had the tools, these revolutionaries argued. We have the tools, they are opiate painkillers, and we're just not using them because we're afraid of addiction, and now we're arguing that these are virtually non-addictive when used to treat pain. Doctors were pressured to prescribe. They were re-educated on the importance of using these pills at continuing medical education seminars. Lawyers told hospitals that they could be sued if their doctors didn't aggressively treat pain, which meant use pills. Very important in all this were Press-Ganey evaluations, which in one sense might be seem like a good idea to evaluate the doctor's performance, but mostly dealt with how well those doctors treated pain. They were very blunt instruments with very sharp effects. Doctors could lose their hospital privileges. Reimbursement became based on a few questions in a survey, and a negative could be a way of a doctor losing reimbursement or, again, hospital privileges. Along with the idea that these pills were now non-addictive was the idea that there was no limit on dose. So if 100 milligrams wasn't working, maybe 125, maybe 250. On and on it went. In 1996, the game changer Purdue Pharma releases OxyContin in 1996, arguing that it is, quote, virtually non-addictive, and that, quote, less than 1% of all people using this drug get addicted right out. The only place they can cite where that's kind of supported is this one letter to the editor. That letter to the editor becomes almost gospel by the mid to late 1990s. It is quoted, first it's called a report, then it's called a study, then it's called a landmark report, then it's called, Time Magazine 2001 called it a landmark study that does much to change what we know about addiction in America today, on and on and on. It was a 101-word letter to the editor. You go to Google Scholar today, you'll find that letter to the editor has been quoted or cited close to, I think, over 900 times. OxyContin was a game changer because, for a few reasons. One was the way it was promoted. It was the first time an opiate was promoted to doctors almost like over-the-counter medicine. So they gave away hats and phone pads and trips to Scottsdale for CME seminars. And there was the CD called A Swing in the Right Direction with OxyContin, with a couple kind of hand in hand walking through a garden, I guess swinging with OxyContin. On the CD had like Andrew's Sisters and Count Basie tunes, that kind of stuff. The reps were constantly visiting doctors. Their motto was, the oxy is the drug to, quote, start with and stay with. And in time, the crusade was extraordinarily effective. Advertising, we do advertising so well in this country, created essentially a pain revolution. Prescribing takes off, not just for oxycodone, which is an OxyContin, but hydrocodone as well. In '96, you just see it taking off like an airplane leaving a tarmac. And a country that barely prescribed opiates became their biggest consumer. Where this was first promoted in the area very, very roughly drawn of Columbus, Ohio to the north, Cincinnati and southern Indiana to the west, West Virginia, western Pennsylvania, eastern Kentucky, eastern Tennessee. That very, very rough drawn area was essentially ground zero for what we're going through as a country. Today, I learned this story as a reporter with the Los Angeles Times, covering drug trafficking in America. And I learned the story of the Jalisco boys, and I pursued that. But as I did that, I also learned how this had affected the rest of the country. And that's when I came upon the story of the small town of Portsmouth, Ohio. Portsmouth, Ohio is far away from here, but in a lot of ways, it's just right around the corner. Portsmouth is on the Ohio River across from Kentucky. It was in its day an all-American town. Had a steel factory, shoe factories, bustling Main Street, 50,000 population. It was where the first NFL night game was played back in 1929, I believe, and a team that later morphed into the Detroit Lions. And at the center of town, kind of like the central plaza of the town, was this enormous football field-sized swimming pool. People used it as a babysitter. It was a place where class almost didn't matter because everybody, factory manager, factory worker, looked the same in swim trunks. The owner, check this attitude out, the owner also owned a shoe factory and decided, you know what, he didn't need the money from the swimming pool. So he reinvested the money in his community, buying more and more land around the swimming pool. And so there were picnic tables and basketball courts and on and dances on Friday night, and people would announce their romances by walking around hand in hand around this swimming pool. People of all classes went to this pool, and the name of this pool was Dreamland. The cycle of life took place at Dreamland. So when you were a toddler, you were in the shallow end with your mom. 7th grade, you were jumping off in the middle there. High school, you were jumping off the diving board, showing off your friends. Young adult, you lost your virginity out in this ever-expanding field. And your children were toddlers at the shallow end of Dreamland, just as you had been. In 1980, in 1980, the steel mill left. Shoe factories began to leave as well. Several of them had already left by that point. Main Street empties out, and in 1993, they dig up and destroy Dreamland Pool. If you get to Portsmouth now, it's now a big parking lot with an O'Reilly's auto parts store there. Dreamland was replaced as a place to see people by Walmart. It was the only place where you could now actually see other people. As the town kind of turns inward, half the population leaves. There's no place on Main Street that anyone wants to be anymore. But with the end of Dreamland, with the end of all that supported Dreamland, came the end of community in that town. A societal immune system was kind of stripped away. The town, as I said, most of the people left. A lot of abandoned houses. Those who remained went indoors, huddled together. Portsmouth became completely vulnerable In the same way that Indians were vulnerable to smallpox when the Europeans came over, this town was now had, with its social girdings and communities stripped away, was now vulnerable, and it became the pill mill capital of America. An entire generation and a half of Portsmouthians grew addicted, as in this town was invented the classic, another business model known as the pill mill. By one doctor kind of invented it. Other doctors, he brought other doctors in to work in his clinics. They went out and started their own pill mills and basically pain management clinics with no pretense at any diagnosis whatsoever. In long lines, people in pajamas waiting for their prescriptions. At the same time, so many pills were prescribed in Portsmouth, Ohio, that this town developed literally an OxyContin economy. Cash did not matter. You could, excuse me, you could buy everything that you needed to live with pills at that point. You could buy food, children's clothes, cable TV service, a refrigerator, cars, whatever. People would do home invasion robberies. They wouldn't steal the cash. They'd just take the pills. Crucial to all this was Walmart. I have a theory that this problem would not have spread nearly as fast in that ground zero area I kind of diagrammed had there been a locally owned economic infrastructure in place, a diverse economic ecosystem in a sense, where everybody owned their own shop, because then addicts would have to go from store to store to store to steal what they needed every day, and every store would be owned by someone who was there ready to defend his store, her store. But Walmart had sucked all of that up and regurgitated it onto their floor, and the only person really standing between an addict and his fix was a 69-year-old greeter making $9 an hour. In some areas of Ground Zero 2, the pain pill revolution was laid over a culture of economic survival through flouting the law, where law enforcement was itself complicit. A lot of these areas were bootlegging areas as well. Pills took to those areas very strongly. Doctors in these areas had become linchpins, crucial to life strategies in the face of economic cataclysm and the departure of jobs. An entire generation in many of those areas that I outlined entire generations formed that had never worked at all. They opted into SSI, increasingly by the age of 21. And at first the calculus was based on getting that $500 to $600 monthly SSI check. But as that pain revolution took hold, the check became really inconsequential. Now the prized item was a Medicaid insurance card. It allowed the bearer to fill with a few dollar copay any prescription that he could get a doctor to write. And more in this area, doctors were buying into the pain revolution. Pill mills straight out of Portsmouth, Ohio were now spreading. And at the right doctor's office, you could get a laundry list of prescription drugs, which could then be filled at a pharmacy for a few bucks with a Medicaid insurance card, and those drugs on the street were worth many thousands of dollars. In the area that I call this Ground Zero, that was one important way pills spread and a black market for them was formed. So as all this was happening, as the pain revolution was hitting hard, in an area that was hit hard by economic catastrophe, pill mills were spreading out of Portsmouth, Ohio. Pills were making the Medicaid card a life strategy, essentially. As all that was happening, those guys from Mexico, from that little town of Jalisco, Nayarit, arrived in Columbus, Ohio, June 11th, 1998. One guy in particular, I interviewed him many a time. The Jalisco boys are not the only heroin traffickers in America. They are, however, important to the story for two reasons. One, they innovate and expand a system of drug trafficking that is nonviolent, dependent on marketing, branding, customer service, rather than the traditional kind of underworld gunplay. Their methods, I always thought, were remarkably similar to those used by Purdue Pharma to promote OxyContin. But also, these guys were the first to recognize and then systematically exploit the coming market for heroin that the new aggressive prescribing of pain pills implied. And they did this beginning in 1998, almost 20 years ago now. They did this just as Purdue was recognizing this Ground Zero area was an area where people were in pain and where docs were more amenable to prescribing. So in that area, a new kind of underworld drug trafficking met a new kind of legitimate drug promotion. Heroin giveaways met free coupons for OxyContin. Friendly taps on the back at methadone clinics met friendly visits to doctors' offices by attractive sales reps. There's no conspiracy theory here I'm alleging. I'm just saying that this began to happen all coincidentally in the same area at the same time. OxyContin was also a game changer for another reason. That was because it became the bridge to heroin. Other small-dose opiates like Vicodin, Percocet, Lortab, and others were combined with acetaminophen or Tylenol. By the time an addict developed a large daily habit to those drugs, he'd have destroyed a lot of his internal organs. So people really did not go from small-dose Vicodin to heroin too much. But Oxy had none of those combined painkillers, Tylenol, acetaminophen. It was just straight opiates, so people began to develop very high tolerances, daily habits of 150, 200, 300 milligrams a day on the street, which meant $150, $200, $300 a day. This, of course, was not sustainable, and they began looking for a substitute, cheaper and more potent than the pills that they were taking. And suddenly, that change in the 1980s in our heroin market, from the Far East to Mexico, Colombia, was all of a sudden piercingly relevant. We would not have a heroin problem today were it not for OxyContin creating huge numbers of addicts with very high tolerances. We probably would not have the problem we have today without cheap heroin from Mexico providing that very easy substitute. And within a few years of this, we saw in this region I've described what we're now seeing all across the country, which is people getting addicted to pills, transitioning to cheaper, potent heroin, and dying. Huntington, West Virginia was the first case that I found where 14 people died in a 6-month period in the year of 2007. But remember, this did not start with drug mafias. This is a unique drug problem in America because it does not start with the underworld or drug traffickers. It starts instead with well-meaning doctors believing something that wasn't always true in their attempt to help us avoid our pain. I was so deep into this story that when I realized this was happening all over the country at the point that I finally got involved in this, 2009, 2010. That it had started in areas that we were used to overlooking, like Appalachia or the Rust Belt. They were our canaries in our societal coal mines, areas that have been, where those very same coal mines have been shut down or laid off most of their people. It had now spread, though, beyond that ground zero area to many parts of the country. The wealthiest suburbs, middle and upper class areas of the country, Salt Lake, Charlotte, Portland. Now nationwide, we have heroin and opiate problems in Alabama, Vermont, Tennessee, and Wisconsin. Children of people who have benefited most from our economic booms beginning in the 1990s were getting hooked on drugs used, of all things, to numb pain. When I realized that is when I realized this was a story about something much larger than simple drug trafficking. This was not just a crime story, a crime book that I was working on. It was about the country, what we had become as Americans. I sought the common denominator between Portsmouth on one hand and Charlotte, North Carolina, or Portland on the other. And I found it, I believe, my feeling, in the last 35 years. In those last 35 years, we spent most of those last 35 years destroying community in America, it seems to me. We have mocked and clawed at the girdings of government that provide the public assets and infrastructure that we take for granted and that makes communal life possible. Meanwhile, we exalted the private sector. We beat communism and thus came to believe the free market was some infallible God. Accepting this dogma, we allowed and even encouraged jobs to go overseas. We lavishly rewarded our priests of finance for pushing those jobs offshore and thus crushing communities. It was a time, I believe as well, when we as Americans began to believe that old rules do not apply to us. We believed that it was simply a natural thing when all of a sudden several baseball players would hit over 60 home runs every year, when it had only happened twice in the whole history of the sport. We believe that when you bundle together thousands of poorly performing whole loans and Standard & Poor's stamped them AAA, that was a magnificent place to invest your money. And we believed that opiates, drugs derived from the opium poppy, 5,000 years of experiment, of knowledge of this plant, that drugs derived from this plant, massively prescribed like a fire hose, would not addict massive numbers of people. We demanded, meanwhile, perfection from government and forgave the private sector its trespasses. We had a president who said, government is the problem, as if to say, we can go it alone. We've already been going it alone. Government isn't necessary. The answer we turned to was the private sector, to shrinking and starving government, seems to me. Yet here, this story is a story of a drug nightmare created by the private sector. When I was doing this story, I realized that for the most part, the only people who were fighting this problem were coroners, cops, DEA, public health nurses, jailers, prosecutors, ER docs, county drug counselors, all of whom were drawing a government salary. In this story, all profits were privatized, all costs were borne by the public sector. Again, jails, courts, coroners' offices, county hospitals, cop, police departments, etc. And the responsible part of the private sector, particularly pharmaceutical companies, is conspicuously nowhere to be found. The Sackler family, which owns Purdue Pharma, is now one of the wealthiest families in America, estimated to be wealthier than the Rockefellers and the Mellons by Forbes magazine, of net worth, the magazine estimates, of $14 billion due to $35 billion in OxyContin sales since the drug came out. But at the same time we were exalting the private sector in this country, we also developed a fear of the public sphere, that outside was where pain resided, that we began to believe that indeed that our children should be spared all pain. Parents hovered over their kids, afraid that they'd feel pain, keeping them inside for fear of the child molesters behind every tree, afraid that they would fail, afraid that they would skin their knees. So we gave them padded playgrounds, trophies for showing up, huge amounts of Halloween candy, keeping them from the painful consequences of their failure. A generation of kids were raised on the fear of pain, on the fear of the outside. A couple was recently prosecuted for letting their daughters go to the park alone. As a country, our fear of pain extended to public discourse. We became all so easily offended at insensitivity, whatever the heck that is. And now it's true of our kids. The Atlantic Monthly last year published a story saying kids who grew up in the era of hyperprotection from physical pain were demanding to be protected as well from painful ideas. They went to college, demanded professors provide them with what are known as trigger warnings in advance of ideas that might provoke strong emotional content. A novel, say, that describes violence of one sort or another. I thought you went to college for ideas that might provoke strong emotional content. Apparently not anymore. Psychology Today ran a story called The Declining Student Resilience that noticed increased neediness in college students. Students had called campus police after seeing a mouse, blaming teachers for poor grades, and, quote, increasingly seeking help for and apparently having emotional crises over problems of everyday life. As a country, I have to say, we acted as if consumption and the accumulation of stuff was the path to happiness. We built into our suburbs a deep and sad isolation and called that prosperity. Added to the mix was the expansion of technology that connects us to the world but separates us from our next door neighbor. We pretend we're informed by 24-hour cable news. In my opinion, as a reporter, these folks are dealers in the drug of outrage that provide little information. They provide mostly heat, alarm, frenzy, and isolation that separates us one from each other. 24-hour news, in my opinion, is just like heroin. Just as addicts confab in their own separate world, don't want to hang out with anybody who doesn't sell or use dope, so 24-hour news has done that to us politically. So we huddle together in little groups, and we don't talk to the other unless we're screaming at them. The result of all this and a whole lot more is that we as a country, I believe, wound up dangerously separate, isolated from each other, whether in poverty or in affluence. We wound up just like Portsmouth after Dreamland closed. Kids no longer play in the street. Parks are underused. Dreamland lies buried beneath a strip mall. Why then do we wonder that heroin is everywhere? Our very search for painlessness, for comfort, led us to it. Heroin, in my opinion, is the final expression of values we have fostered for 35 years. Heroin, remember, turns every addict into a narcissistic, self-absorbed, solitary hyper-consumer. A life that finds opiates, turns away from friends and family and community, and devotes itself entirely to self-gratification by buying and using the one drug, the one product, the drug that most makes being alone not just all right, but preferable. The crack epidemic had the crack house as the hallmark institution. This epidemic, so quiet and silent, as I said before, the hallmark institution is the private bedroom. Those bedrooms that are the sign of our enormous prosperity, those bedrooms where every mother thought their kid was safer than out on the street. In those bedrooms are where kids are hiding their dope, shooting up, and dying. Isolation is heroin's natural habitat. I believe, therefore, more strongly than ever that the antidote to heroin is not naloxone. The antidote to heroin is community. If you want to keep kids off heroin, make sure people in your neighborhood do things together, in public, often. Break down those barriers that keep people isolated. Create your own dreamland on your block. Make your kids ride their bikes outside. Let them skin their knees. Let them fail. Don't protect them from those consequences that teach them so much. Today, obviously, as we said, it's an enormously difficult problem reaching coast to coast. The Jalisco boys that I wrote about were once big fish in small ponds. That pond is now an enormous ocean with many, many more people involved in it. Sinaloa cartel being one. We now have fentanyl and fentanyl to deal with. And my hunch is, I don't know this, but my hunch is traffickers have turned to that in part because we have outstripped their production capacity for opiate heroin. The good news is that there is no solution. We tried the solitary solution, the sexy solution, the silver bullet, the magic answer, and look where it got us as Americans. Indeed, over and over as I researched this book, this story seemed to get back to isolation versus community. We tried pills as the one solution to all pain, tough on crime as the one solution to all addiction, parents all alone in their bedroom, afraid to talk to anybody, crying themselves to sleep at night. This attitude that we can do it all alone because we always have, that we do not need each other. I think it's time we stop believing that there's an easy way out, that old rules don't apply to us, that we have no need for each other. No, there is no solution. There are, however, many solutions. Happily, not one of them is sexy. None will do the trick alone. Each is one small part of a mosaic, a cluster of solutions that each community, each region, each state must try. I think it's time we rethink jail. In Kentucky, they're doing this and with remarkable, I think, effect, transforming parts of jails into full-fledged 24-hour rehab clinics. It's the one place where we can find capacity quickly and cheaply is in our jails. We just have to rethink how to do it, and I'll happily talk more about that later. I think it's time we really support our cops. Just to say that we cannot arrest our way out of it does not mean that we can therefore treat our way out of it. This is a supply story, started anyway with supply, and only with diminished supply will we give addicts leaving rehab a fighting chance at recovery. I think we need to listen to and respect our public health folks who have shown that with proper budget, they can do amazing things. We have some of the best public health folks in the world in America. I think doctors and nurses must stop prescribing, above all, so many of these pills. There is no solution to this problem that does not involve that. I'm a layman. I'm not a doctor. I'm not a medical professional. But no one yet has given me a good explanation for why doctors prescribe 30 days of an opiate for acute pain that will last half a week. I think insurance companies must start reimbursing for a wider variety of pain strategies. I think hospital administrators must take doctor evaluations the way they're currently constituted out of the calculations of how doctors are paid. I think government also must understand the pernicious, pill-extorting effects of those doctor evaluations as they currently exist. I believe, I've come to believe that medically assisted treatment is extraordinarily important. I'm a layman, but I believe the new context of plentiful dope looks to require medically assisted treatment more than ever, though it is now crucial to how that is implemented. Addicts need that shield when they're leaving treatment, particularly now with our streets awash in opiates of one kind or another. After many years in Mexico, I'll just say I believe we must develop a lasting, consistent, firm relationship with Mexico that both helps and urges that country to change. Above all, though, American patients must start taking broader accountability for their health, their wellness, their emotional, physical, and neighborhood health. We must come to understand the importance of community and stop allowing things that destroy it. I'd say, for a start, let's just all turn off 24-hour news and talk radio for a month and then see how you feel. You go through withdrawals, you start sweating, you won't be able to sleep, you know. But at the end of 2 weeks, you'll have a fresh, new, happy perspective about the country where one did not exist before. But this is the kind of stuff that isolates us and doesn't require much of us at the same time. You don't have to work hard with 24-hour news to develop an opinion, or it'll give it to you. Just the way heroin takes away your cares, this stuff relieves you of the tough work involved in being an American. If Americans are exceptional, it's through this work required of us in citizenship, civic participation, being accountable for our own political and our own consumer choices. We got away from that, and we got away from what's best about this country, it seems to me. We rid ourselves of things so essential that they have no price, and in return, we have been invaded by cheap crap. Remember, heroin is what you get when you destroy dreamland. The best good news is this problem is no longer private. As I was saying when I was writing the book, it was a very private thing. No one wanted to talk about it. Now, parents are stepping out, telling their stories. That's healthy. There's no longer just a thin line of public employees fighting this alone. Heroin, it turns out, is fearsome enough to bring us together. Heroin, in fact, I think, may be the most important force for change in America today, for it pushes us to recognize our own isolation from each other. Some of you I know are on the front lines. To you, I say again that community is the response to a story about isolation. I think the new movement in behavioral health, treating behavioral health, homelessness, and addiction as one thing, a kind of a community response to this one problem, could be extraordinarily potent. I think certainly, it seems to me as a layman only, to lie on the right path. Treating everything together as a kind of a holistic way, as I believe what this epidemic is showing, what we should have been doing all along. Cops and public health workers, I think, have to come together instead of working in isolation themselves. I'd say they should go out for a beer, get to know one another, get each other's cell phones. This is an epidemic that combines law enforcement and public health in a way perhaps no other has. It's extraordinarily important that we make those bridges. I think we need to leverage all that talent and energy. I have faith, again, as I said, that on that path lie solutions that we have not imagined or thought possible. What I do believe is that in isolation, all problems seem insoluble. I think it's time we enlist doctors, listen to their stories about the pressures they face from us when they suggest to us that we change our unhealthy lifestyle and habits. Above all, though, I cannot end a speech without making a pitch for a much broader use in this fight of parents of addicts. Parents who have lost their kids to this awful addiction, awful disease. They are out there now. They want their stories told. They want to be used in this fight, I think. They need it to salve those lacerating wounds that comes from having lost children. If you do, I think they will thank you. I think your town, I think your state will thank you. Your country will thank you. And I thank you very much. Thank you very much.
morning, everybody. I think it's probably the third or fourth time I followed Sam Quinones as he's talked about this issue, and it's a daunting task. I too am a Sam Quinones junkie and groupie. I guess I shouldn't say junkie here, right, in this context. We're trying to avoid stigmatizing language, and I just perpetuated it. But if you haven't read, and I have no financial interest in this, but if you haven't read Sam's book, I really encourage you to read it because, you know, I've been a public health person for a very, very long time and spent the bulk of my career at the Department of Public Health in Massachusetts working with our Medicaid program in this. And while we're here talking about federal and state strategies, the role that Medicaid can play, I think Sam really articulates what I think many of us feel and have come to know about this issue, that it really is about community, and it's about community coming together. And I, with attribution, use Sam's quote when he talks about the fundamental solution to our current opioid epidemic is community. And I really believe that, you know, as I've traveled the country for the past 4 years, you know, I think my main task has been to bring community together again. To bring every stakeholder in the community and understand that we have an obligation to each other as we think about this issue. And as a person in long-term recovery, I can tell you, you know, that isolation, that the path to recovery is about getting outward focused instead of inward focused and really becoming a productive member of the community. And I do believe that's where our solutions lie. I want to thank Shannon and Matt for hosting this today. And I think, you know, we have all talked about just the staggering magnitude of this epidemic. And this is not, I very rarely take issue with Sam, but this is not a drug crisis. This is a health crisis. So we are approaching mortality rates that we have not seen since the height of the AIDS epidemic. So this is our #1 health priority. And I am truly glad that state Medicaid directors understand the role that mental health and substance use disorders play as it relates to this issue. You know, we're here today, you know, because our opioid epidemic, and while it certainly has some interesting and kind of idiosyncratic roots, much of the reason that we're here today is because of some really long-standing issues of how we have looked at substance use disorders. So, you know, one is the lack of insurance coverage and inadequate coverage for people with substance use disorders. The lack of access to treatment, particularly access to medication-assisted treatment, and particularly access in rural underserved parts of the country that have been hard impacted by this epidemic. The fact that substance use treatment isn't fully integrated in primary care and other medical settings. And quite honestly, the fact that our old way of dealing with substance use disorders just isn't going to cut it anymore. So we know that this is a national crisis, but it manifests itself as a local problem. Overdoses happen in our communities. Our local police officers and first responders are often the first to see it. And friends, family, and neighbors feel the effect when a loved one dies. So we have to work together to make sure that treatment is easier to access, which will help people reach recovery and save their lives. So there are key actions that the federal government and the states can take to improve access to treatment. And we all know that state Medicaid programs have a big role to play here because people on Medicaid have a higher prevalence of substance use disorders and are particularly affected by the opiate epidemic. So that's what I really want to focus on today is kind of what the federal government has been doing to end this epidemic and how states and state Medicaid offices can play a huge supporting role in that. So first and foremost, as Sam said, the most fundamental change that the federal government has been taking is how we approach people with substance use disorders. And for too long, we've viewed individuals with substance use disorders negatively. And quite honestly, we've left it up to our law enforcement to solve our substance use problems. Our jails and prisons should not be our de facto substance use treatment programs. And we know that doesn't work. The administration recognizes that substance use disorder is a disease and that we can't arrest our way out of this crisis, and that we have too many people incarcerated instead of receiving the treatment that they need. President Obama has made clear that addressing the opioid epidemic is a top priority for his administration, and he shifted our approach to more focus on prevention, treatment, and recovery than ever before. You know, over the last couple of years, like Sam, I've been traveling the country in places like Albany and Knoxville, Toledo, and Albuquerque. I've spoken with people in recovery, parents who've lost loved ones, and local leaders. And time again, I hear the same thing. Evidence-based treatment is too hard to find. People often have to wait weeks or months before they get the care. And if they do get care, it's based on acute and episodic disease model. And sadly, it's not surprising that in the United States, only 1 in 9 people with a diagnosable substance use disorder get care and treatment for their disease. 1 in 9. That's unacceptable, and this has to change. That's why, in addition to all the actions that we've taken, the President has requested $1.1 billion in new funding from Congress to expand prevention, treatment, and recovery services, including medication-assisted treatment. But we all know that Congress has failed to act. I actually think it's reprehensible in the midst of one of our greatest health crises that Congress has failed to act to make sure that people have adequate access to treatment in the United States. And tomorrow, you might have something to say about that. So as you all know, and as Sam talked about, medication, when combined with other counseling services, is the gold standard for treating people with opioid use disorders. And buprenorphine, methadone, and injectable naltrexone have all been shown to be effective. Just last week, the General Accounting Office released a report on showing that medication-assisted treatment, when combined with other supports, is better than abstinence-based treatment and treatment without medications. Treatment works, and people with opioid use disorders need to access the full spectrum of medication-assisted treatment and the full continuum of care to make sure that we get them to recovery. So because the effects of this epidemic are local, most of the $1.1 billion would go to the states. We have a breakdown on our White House website to show how much each of your states would be eligible for should Congress pass this funding. This will go a long way to turning the tide on this crisis and help people get back their lives. But since Congress hasn't acted to provide this funding, we continue to look at every option that we can take to make sure we're making a dent in this epidemic. This summer, we were able to raise the cap on the number of patients doctors can treat with buprenorphine in an office-based setting from 100 to 275, which will help expand access in communities with wait lists. Last summer, we issued almost $100 million was awarded to close to 400 community health centers to ensure they're integrating substance use disorder treatment as part of their services. And soon, nurse practitioners and physician's assistants will also be able to prescribe buprenorphine. And we are also working with states to expand access to medication-assisted treatment. This summer, I sent letters to all 50 governors about this. And in January, the Center for Medicare and Medicaid Studies Services sent a bulletin to your state Medicaid office about the opioid epidemic to make sure people have access to the full spectrum of treatment options. And we're working to implement parity regulations to ensure that both public and private payers reimburse and support people with mental health and substance use disorders and ensure that they get equitable care. So this disease deserves the same level of care as other diseases like heart disease, diabetes, and cancer. 10 days ago, the administration released the President's Parity Task Force report to help get us there. This report makes recommendations that will ensure parity regulations are correctly and appropriately implemented. As you know, this law eliminates the coverage restrictions on mental health and substance use services, like annual visit limits, higher copays, and different rules for how care is managed, if they do not also exist for physical health conditions. It's critically important that you pay attention to parity because it affects all of us, including Medicaid CHIP final rule applies to parity coverage offered by Medicaid managed care organizations and Medicaid alternative benefit plans, as well as CHIP. And CMS added parity to its review of plans subject to essential health benefits. We need parity to go smoothly and appropriately in compliance with the law. So we're working to make it easy as we can by making tools, initiatives, and funding available to help you comply with these new expectations. For example, CMS has pledged $9.3 million to help state regulators assure compliance with parity regulations. The task force recommended the development of a parity analysis toolkit to help you assess compliance for Medicaid managed care organizations and CHIP programs. And SAMHSA will hold state policy academies for state regulators and officials on parity in both public and commercial plans. There's also a host of information available on the HHS website for how states can approach parity, including best practices. And there's a one-stop consumer portal to help people learn what parity means for them and what they can do if they aren't receiving comparable care for mental health or substance use disorders. Making sure people have access to potentially life-saving mental health and substance use treatment is a key to improving the health of our nation and helping people with these diseases live healthier, more productive lives. As important as parity is, it's not the only thing we need to do, and I completely agree with Sam when he talks about that this is a complex problem that requires multiple solutions. Ending this crisis will take all of us working together, and everyone has a role to play, from the Medicaid directors here today to your governors, members of Congress, and mayors, to public health officials, treatment providers, law enforcement officials, faith leaders, parents, teachers, and community members. And because people on Medicaid are vulnerable to developing substance use disorders, there are key things you and your governors to do to end this crisis. You can make sure you're offering quality care and have network adequacy standards and appropriate Medicaid coverage in every corner of your state. This includes offering a robust treatment benefit, including making sure all 3 FDA-approved medications for opioid use disorders are part of your formularies. And it includes comprehensively reimbursing for treatment services so providers will offer them. You can remove methadone for pain from the preferred drug list for all Medicaid formularies and make sure that the opioid overdose reversal medication, naloxone, is on there without prior authorization. You can also work to make sure that you're reimbursing for non-pharmacologic pain management benefits. You can make it easier for people to access naloxone, even if they have an undiagnosed opioid use disorder, by allowing any patient who requests it to receive reimbursement for it. Rhode Island recently passed a law requiring insurers to cover naloxone for anyone, including bystanders and family members. I know that part of your job is watching the bottom line, and that's why it's so critical that you offer quality care and invest in treatment now to create benefits down the road, including reduced healthcare costs. Naltrexone is expensive, but it's far cheaper than a liver transplant. Washington State is a good example. The savings generated by treating people on Medicaid who have a substance use disorder were greater than the cost of the treatment itself. So not only is intervening early the right thing to do, it can also help your bottom line. In 2015, CMS offered a unique opportunity for demonstration projects to provide the complete continuum of care under an 1115 waiver program and required the American Society of Addiction Medicine criteria to be used. California was one of the first 1115 projects approved and has paved the way with their demonstration project, and I was glad to learn that my home state of Massachusetts is now the second. It includes evidence-based benefit design covering the full continuum of care, requires providers to meet industry standards of care, and it includes a strategy to coordinate and integrate across systems of care. More states need to do the same because Medicaid reaches many people who are incredibly vulnerable and is one of our best tools to ending this epidemic. So you are uniquely positioned to make a real difference. Last October, President Obama said something while we were in West Virginia that really resonates with me. He says, when it comes to substance use treatment and recovery, those things are possible if we work together and if we care about each other. If we do these things, if we keep working to expand access to treatment, we'll get far closer to ending this epidemic, and we'll move our country from crisis to recovery, and we'll save countless untold lives in the process. Thank you very much for the work that you do.
So I'm going to hand it over to John. I'm going to hand it over to John and ask for his reactions and comments, both from his perspective of being an Ohio resident, running the Ohio Medicaid program, and I also think on behalf of the Medicaid directors writ large.
So thank you both for coming today to speak to all of us. It's great to have you here. And if you haven't read Sam's book, you have to. It's an amazing book. I've been reading it over the last few weeks. Tom Betlach, the president of our association, was adamant at getting Sam here and making me read the book, and I was like, okay. And it's an amazing book. You have to read it. Even if you're not in that area, this issue touches all of our lives. And I'll talk about that a little bit in a second. So as a Medicaid director, right, we've got big jobs, a lot going on. So I am lucky enough in 2011 to be asked by Governor Kasich to come to the state of Ohio. I moved my family from D.C., we lived in D.C., to Ohio to take on the Medicaid program in the state of Ohio. We, at that point in time, we have a biennial budget. We have an $8 billion hole, so $4 billion a year that we've got to fix. The department that I was going to run was inside, the Medicaid department was inside of the Department of Job and Family Services. I was not a cabinet member at that time. I was a deputy director. Yet at the same time, to understand a little bit about how Ohio government works, there's 26 cabinet members. We don't have secretaries, we have cabinet members. There is a separate cabinet director for the Department of Addiction Services. It was Orman Hall at that time. We have a separate Department of Mental Health. That was Director Plauk. She was actually Medicaid director 2 times before me in filling in roles. I've worked with her for years. We have a separate Department of Health, which was Dr. Wimso. We have a separate Department of Aging, who is Director Bonnie Berman. They all run pieces of the Medicaid program. They're all cabinet members, and I'm not. I'm a deputy. So guess what happens when you go to the governor's office with requests before the Kasich administration? Everyone else told the Medicaid director how to run the program. So as a part of me coming there, I said, the only way I'm going to do this, and I talked to Director Greg Moody in the Office of Health Transformation. I said, we have got to move Medicaid out of Department of Job and Family Services and elevate. And Greg agreed. There's a long-standing piece of this. The reason I bring that up is because I come there to work on filling this $8 billion shortfall, because that's what I'm known for, is fixing Medicaid programs and how to bring down costs. And then also, what do? I implement MMIS systems, which I did in DC successfully, and creating standalone departments, what I also did in DC. So that's what I go there for. We're at the state of the state, and at the state of the state, there is a number of mothers up in the balcony wearing shirts, and they all say Solace on them. And those mothers, if you read the book, they all had kids who died because of heroin. The governor told all of us at that cabinet meeting after that one that we were to form a task force and focus on this issue and fix it. He didn't pick out one of us. We all did it. We also brought in the boards, and we all worked together on how to address this issue. So you're sitting there thinking, well, no, Johnny, that couldn't be. Not everyone was there. The Department of Aging wasn't there. Yes, the Department of Aging was there. Director Bonnie Berman sat right next to me as we were working on this issue because you know why? Elderly people had the drugs in their cabinets. So they are the ones that were, if you read the book, selling their drugs. And we knew it. We saw it happening. We had everyone there. We had public safety there, workers' comp, and we were all coming up and coordinating our efforts to figure out what we could do together to fix this issue. Now, at the same time, we've got in the state of Ohio, expansion hadn't happened yet. That was still, coming on its way. And at the time, we didn't call it expansion. We knew at that point, right, that we had to expand the program. It wasn't a question because we didn't have the court rulings yet. So where did funding come from for these services? They all were done at the local level. In the state of Ohio, all that funding was done by local ADAMS boards, Addiction and Mental Health Services boards. So they had to have levies at that local level. Even for the Medicaid services, so we covered parents to 90% of the federal poverty level, and obviously age blind and disabled. For those services, which were run out of the Department of Mental Health and then the separate Department of Addiction Services, those 2 separate departments, they did not get the state share appropriated to them. The locals had to put up that state share. So what happens? Well, locals often would run out of money. And so there would be waiting lists for services. And that's if you were lucky enough to be on Medicaid. If you weren't on Medicaid, there was no services. So what happens? There's not a lot of good providers. And you're talking about some of the providers down in the Salo County. They were limited by the dollars that they had. So one of the first things we did that came out of this, that came out of our task force was we elevated funding. So we actually took the funding away from the locals, and all the Medicaid funding came from the state. We took that one step further. We actually took the two departments, mental health and addiction services, and combined them into one. And Director Plouk became the director of both of those. And then Orman Hall helped as deputy for a long period of time before then moving over to the courts and helping them. Then one of the things we did was, I'll never forget the day that I went in to talk to the governor about the decision of should we expand Medicaid or not. When I went in to talk to him, people always ask, well, what was it like, John? Was it, it was a long discussion and you guys fighting back and forth? And we walked in to talk to him, and it was about a 5-minute discussion. And that discussion went like this. So, John, you're telling me that I could help 300,000 people, and yes, that's what we thought the number was at the time. We could help 300,000 people who are drug addicted and have mental illness, and it won't cost us anything at the state level. And I said, yes, Governor. And he said, we're doing it. Tracy Plouk was right after me coming in and talk to the governor, and governor always tells a story so I can tell it. She started crying after he told her that. So we've all been working together on how to fix this problem and moving forward. Now, we've made some progress. There's a whole bunch of other things we've done. And you see the number of prescriptions in the state of Ohio coming down very, very quickly. The issue that we have is prescription deaths are coming down, but heroin deaths are going up. So we are fighting those. And why is that happening? There's a couple of different reasons behind that. But I want to bring up a couple of things that were said earlier about, as Medicaid directors, why are we in this bind? So on one hand, we know the Medicaid program can help this problem, right? We can find the funds then to serve people to get them the services they need. On the other hand, we've got people, as we saw, signing up for the program, getting in and getting the Medicaid card and abusing, and that's how they get their drugs. So you have to understand, early on, I was getting a lot of pressure from legislators of saying, whoa, if you expand Medicaid, all you're going to do is put more pills into the system, because that's what Medicaid was to them. It was just a way, from those legislators' minds, of getting more pills to people, and that's what they wanted. We had conversations about, should we not? They didn't want to expand because they thought it would make the problem worse. And we were saying, no, you've got this problem anyway, it's going to happen. Then another example is the issue that came up by the 1115 waiver. I got that letter. I've been working in Medicaid for 21 years now. I've written waivers myself. I've gotten them approved. I've gotten 2 waivers approved in matters of 3 months, the quickest ever. You know how hard it is to do an 1115 waiver? Super hard for people in this audience. And you know what's even harder in 1115 waiver? Doing all of the paperwork on the back end, the evaluations to prove that it works and everything else on the back end. And then, when you prove that it works after 3 or 5 years, you get to go through the whole process again to negotiate the waiver and go through that process. So it's not easy to do that. It sucks up a lot of time for all of the things that we're trying to do. So you're balancing those two different pieces at the same time. So there's a lot we can do, and I think there's a lot we are doing. Lastly, we do also have border issues, and those were touched on a little bit in the book. Actually, the one doctor that was mentioned was actually in Kentucky. So we in Ohio are trying to figure out what do we do? Like, how do we stop this guy? Because remember, this again was before some of the ACA provisions went into place, and there was no order in referring. So people were just walking in with prescriptions. You didn't need to know who it was, and they're just getting prescriptions filled and filled and filled. And we can't stop that doctor. We actually worked with Kentucky on that. But you have people going across the border in either direction. And then if one of the states decides not to cover those services, what happens? If people just move across the border, and all you have to say is, I live in this state, and that gets you the services. One last thing, too, then, was, as we were talking on medication-assisted treatment, it's amazing. And we had plenty of debates over how to do it, and what we would cover and how to cover it. And even with all of that, it was still difficult to move through. We mostly serve people through managed care plans in the state of Ohio, and some of them are here, and they're great plans, and they're great to work with. Yet I constantly would get these calls about, John, they're requiring a PA for Suboxone. They're requiring a PA for Vivitrol. We told you to take that off. And I said, I did. I talked to the plans. We've taken it off. There's no PAs. And so I'd call the plans and I'd say, hey, do you have PAs on these things? They'd say, no, we don't have PAs on it. So I'd call back to center and be like, there's no PAs on it. Then we get somebody call from one of the courts and say, they got PAs on this again. And we're like, what's going on? So I'd call, and finally we were trying to figure out what the issue was. It is true, there was no prior authorizations. There's no prior authorizations. But it was the process to get the drug. And here's one example. So one of the things that we did was we started drug courts, pilot drug courts. So you've got an addict who is there. They've been arrested, they've been deterred, they're going through the drug court, and they've got people there helping them out, and they want to get them one of these drugs. They have their own 340B pharmacy there. And so they got the addict there, they just want to give them the Vivitrol shot right then and ready to go. But instead, some of my managed care plans said, no, you can't use that pharmacy. You got to use our specialty pharmacy. This is an expensive drug, so we can get it cheaper over here. And so you can't get it today. You have to wait till tomorrow. Again, people were trying to do the right thing, and they were set up in processes, but we had to discover some of those things. So some of the things that we worked through, and my plans really did step up and make those changes, but it wasn't easy. So those are just some of the different views of both, from a Medicaid director, the issues we have to do, and then also what we did in Ohio.
Thank you, John. We have about 9 minutes left. I do want to take just a point of personal privilege, too, and just say we are one of the states that's actively been working on the 1115 waiver. We started working and submitted something last July, so July of 2015. It's our hope to be implemented, have coverage available and ready to roll by next July, so 2 years. 2 years, there are people in Maryland that have been waiting for Medicaid-covered addiction treatment in IMDs, in community facilities that we know, again, very much similar to what John was talking about the local dollars and leveraging those local dollars. That is truly battles in the trenches. I don't know, Mike, you want to react to that?
But it's interesting having, one of the people who was responsible for the kind of state financing of addiction treatment services in Massachusetts, and something that John said that is incredibly important, because we know that even though Medicaid plays a large role, there is other funding that's coming to states to look at the financing system of addiction treatment services for a continuum of care. One of the things that we've done on the federal level is preserve the Substance Abuse Prevention and Treatment Block Grant to make sure there's still safety net funding for people who are uninsured or for the full continuum of care, as well as other grant opportunities to do that. And so I think, one of the important things, quite honestly, and it seems relatively simple, but I think it's really important to do an inventory of spending in your state, both in terms of Medicaid, insurance, and other safety net funding, to see where the funding is and to look at that continuum of care and to look at, do you have a continuum of care that supports people, not just for acute inpatient care, but because we really know that that's only the first step in people's recovery, that it's really longer-term treatment. The second thing I'll say, and this is some of the parity stuff that just came out, is we just published part of what the Department of Labor and HHS just published is a Warning Signs 2.0 that looked at some of the issues around authorization, fail-first therapies around those issues, because I think it's really important. Those are some of the biggest things that we hear from both commercial insurance and people on public plans is often there's a covered benefit, but it's the authorization process or fail-first policies that seem to still be an impediment in terms of people getting access to medications.
I wanted to ask a little bit about the community comments that Sam made, which I think are, certainly resonated very much with me, both as in my role as the Medicaid director, also as a parent who lives in the suburbs. It certainly, hit home, and I wonder where you think that the healthcare system comes together with some of that. We talk a lot about social determinants of health and how we can use those social determinants of health to inform the care that we're buying. And I wonder if you've given any thought to how you think that the healthcare system can start helping or supporting building that community that you talk so passionately about.
Me?
Sure.
Yeah. Well, I confess to not being an expert on America's health systems. I think, first of all, it's in the health systems really where as I said, there is no solution to this problem that does not involve doctors reassessing how many of these pills they prescribe. I don't see how that we move forward. If you're in a hole, you got to stop digging. One way to stop digging is the main way to stop digging is to just reduce the amount. And it does not mean you will never hear me say we should never use these pills. They provide they're valuable tools in certain areas of medicine, seems to me. This coming from doctors, I'm very want to be very clear and humble about the fact that I'm not a doctor. I'm a layman here. But I'm doing a story now on Kaiser Permanente in Los Angeles, which kind of took a community activist role with regard to this topic, it seemed to me. They were understanding that a lot of the pills that they were prescribing, primarily brand name opiates, were particularly popular on the street because you knew what to ask for, Percocet, Vicodin, and I think those were the main two. There were a couple others maybe. And as they began to get into this topic, they began to realize that this was an issue, and they took what to me seems a very community-minded response, which is to say, we are going to, first of all, look at how we prescribe, and then we're also going to cut back on the number of brand name opiates, because on the street, those have a much higher value. And over the period of the last 5 years, I think they've really curtailed opiate prescribing. To me, health systems in this story, that is one of the main ways that health systems in this country can be part of a community solution. They unlike anybody, nobody else can do that, And the problem is, of course, that the big systems actually have an easier job of doing that. They have lots of statistics on hand. They kind of have a top-down network, kind of so to speak, and so doctors sometimes, like in Kaiser, do kind of have to take orders to a certain degree, and so you can be ordered to. They like to think not, but I think that's kind of part of the idea. The real problem is, of course, at the smaller clinics and this kind of places where a lot of doctors continue to prescribe. But my feeling is that health systems need to recognize their place in our country and their community, and that what they do, particularly when pill prescribing is concerned, has an enormous effect. This is an enormous supply of pills out there, even today, that is unprecedented of opiates in the history of this country, and it's, I would say, up to doctors and hospital administrators and HMOs, et cetera, to really get down to the details of how to change that. They can do that. It's being done. It's just they need to get serious about it, and some places they have.
We've seen it in Ohio where systems have gotten involved, but I want to go back to it's more than just health systems, it is community. And so, for instance, I live in Dublin, Ohio, a suburb of Columbus. It's one of those all-American suburbs, and you would never think that this issue would be there. Heroin and pills is a big issue in our schools. And our schools did not stick their head in the sand. They just had a community forum 2 weeks ago, and they talked about heroin and pills. And they had people then from the health systems and nationwide children's hospitals there, because I'll just give an example. One of our neighbors, they had a son who was a all-star lacrosse player at our high school. And our high school, we're the one we have is we win state championships in the country club sports, right? Boys golf, women's golf, tennis, lacrosse, that's where it is. We've had a number of kids die of heroin overdoses. He had this one family had 8 kids. Their son, lacrosse player, hurts his shoulder, goes to the doctor and starts getting prescribed pills for a shoulder injury, and that's what led to his addiction. He's been through inpatient 3 times, and he's still struggling with that. So it was also the school that's involved in talking about this. And yes, it is true that in our high school, the kids had pill parties where they'd go to their parents' cabinets and get their pills and dump them in, and they'd pick one out and take it for the party because everyone thought it's a prescription. It's not going to hurt you. There's nothing that's going to happen. So, it's not just the health systems that we need involved. It's the schools, it's local government, and everyone involved to really look at this issue and open some eyes. And that's what I think in Ohio, we've been starting to see more of that.
I'll also add that I think Sam's comments really underscore what we know around prevention, right? So some of the things he was talking about really underscore kind of the risk and resiliency factors that we know go into community-based prevention programs. You know, certainly I don't mean to diminish the addictive properties of prescription pain medication, but you know many people with opioid epidemics started at a very young age.
Yeah.
And you know, we know that there are genetic factors, but we also know that there are environmental factors. You know, the presence of a loving, caring person in someone's life, a sense of community and community identity. You know, these are all the risk and resilience factors. And it's why, from a federal perspective, we actually push prevention programming down to the local level, because it really does require every key stakeholder at the community level to come together to identify what are those risk factors of as a community, and to really build community level resilience, because we know fundamentally that's what we have to focus on. You know, I've been doing this work for a very long time, and you know, and while there is some special significance and you know impact with the opioid epidemic, that you know it's some of those community resiliency factors that we really have to address if we're going to deal with substance use issues in a really substantial way.
Yeah.
Well, we are out of time, but I want to give a big round of applause to our panelists and to Mr. Quinones. Thank you.
Thank you.
I do hope that everyone heard the energy and passion that all of these gentlemen have in this, this work. It's certainly something that has been front of mind for all the Medicaid directors, and appreciate all of your engagement and support on all ends of this issue. So with that, I'm going to hand it back to Matt for logistics and next steps.